Hello again, everyone. Thank you again for being with us in this improving flow stream of the HACA conference. We now move on to what sounds like a very intriguing presentation on actionable insights to reduce delayed discharge in day surgery, and the role that linked data and clinical analytical collaborations can have in that. This will be presented by Nora, who's a senior information analyst, statistician, and joins us, I believe, from north of the border at NHS Lothian in Scotland. This is the first of our insight sessions, which are slightly longer at 25 minutes. Again, there'll be some chance for Q&A at the end, so please use the Q&A function to ask any questions. I'll now hand over to Nora for the presentation.
Thanks for a great introduction, James, and pleased to be here. So I work in Scotland. I work in a clinical health board. I'm an in-house analyst. So it's quite nice to be able to work directly with frontline staff. So today, well, first of all, I'll start by move my slides. Oh, there we go. I'll start with a disclaimer, which is I'm going to be speaking a lot about delayed discharges. This is not the usual delayed discharge definition in the broad healthcare system. I'll be focusing on an operational definition for the day surgery unit, which means patients that were not discharged on the same day as their procedure, because as day surgery unit suggests, they are expected to be discharged that same day. So with today's talk, I have three aims. I want to demonstrate to you the power of analyzing linked data to achieve strategic objectives from a health board by linking all these massive amounts of health records from various different sources that are listed there. Also, provide some understanding on the predictors of delayed discharges for day surgery unit patients. And finally, use these data insights to produce impactful operational changes that improve quality. So a bit of the context of this piece of work. We collaborated with anesthetists from the Royal Infirmary and hospital managers as well. And I was the analytical lead from the analytical side of the team. So it was hospital and analyst collaboration. They had a target, which is that 95% of the day surgery patients are supposed to be same-day discharges, which is quite ambitious and above the British Association for Day Surgery standards. And they came to us with a problem. They wanted to measure their DSU performance, and they also wanted to understand what factors contribute to delayed discharges using a wealth of linked data so that they could lever that data to achieve their target. And finally, we provided them with bespoke analysis and then a future plan to evaluate the changes that we made. So when we looked at their performance, their goal is 5% of delayed discharges, but their performance is actually 30% of the patients. Nearly 1 in 3 is a delayed discharge. These varies obviously over time. Okay, so the questions we wanted to address was what factors contribute to these delayed discharges and how big is their contribution? So looking at significance, direction, and magnitude of the effect, right? Is it a positive effect or a negative one, and how big is it? The way we went about addressing this is using logistic regressions, so generalized linear mixed models, where delayed discharge was a response variable, and we put in a bunch of predictors that the clinicians thought might play a part or wanted to test. And these could be grouped in 4 categories, those related to patient health, demography, service-related predictors, or medical practice-related ones. All of these was done using reproducible analytical pipelines. So code is up for sharing. So I'll hone a bit more into the model. So we had a sample size of 6,000 patients. And as I said, the response variable was delayed discharge, yes or no. And then I'm going to tell you all the things that went into these 4 categories. So in terms of demography, age, sex, deprivation, the Scottish Index of Multiple Deprivation, whether they had a next of kin. All of these in red are patient health-related characteristics, because one of the working hypotheses of the clinicians was that maybe their performance was getting worse because they were getting more ill patients or patients with poorer health. So we analyzed loads of these things, including frailty, which is a very interesting electronic frailty index, which is something that I don't know if in England, but in Scotland we do have, and I'm happy to expand more on that in questions, but it's a continuous variable that picks up frailty markers. And then service-related factors were the surgeon identity, the specialty, the temporal factors, the time of the operation, and things like that. And finally, medical practice, the type of anesthesia, the type of procedure, and then we ran 3 specific models looking at the total amount of opioids a patient received, the amount of every specific opioid that they received and how that affected delayed discharges, and also antiemetics, which are anti-nausea medicines. So in terms of the results, all the significant factors are the only ones that are not scratched. So we did not use model reduction. And from here, you can see that we don't have any evidence that patient health-related conditions have an effect on delayed discharges. All the red things have been scratched off. And finally, we had the same consistent pattern for all the 3 medical practice models that we ran. Now I'm going to show you the size of the effect of those significant factors. I'm going to show you an odds ratio plot. Everything to the right of the odds ratio plot in red is going to has a negative effect, increasing delayed discharge chances. Everything in blue reduces the chances of being a delayed discharge. So here you have all of the significant factors. And what is really striking is that everything except the things that I highlighted in yellow are things that can be known in advance. The only things that are not known in advance is the pain and the nausea that the patient reports in recovery. So basically, this debunks the working hypothesis that the medics had, which is no, health-related conditions are not playing a significant effect in delayed discharges. And the good news is most of the things that contribute to that can be known in advance. So using that, we co-designed 4 actionable insights related to changing operational metrics, improving prescribing practices, safeguarding our efficiency gains, and evaluating prescribing consistency. I'll go through each of them and the evidence that gave rise to them and the actionable insight concretely. So in terms of changing operational metrics, we found that the type of procedure that patient went for really mattered. So here is again another odds ratio plot with the different types of procedures on the y-axis, and then you can really see that patients that went for a thyroid surgery were 117 times more likely to be a delayed discharge. When we try and produce our best estimate of the probability of patients being a delayed discharge, depending on the type of procedure, we see that if you're thyroid, again, nearly 100% delayed discharge, right? So what did we do with this information? Well, in collaboration with the clinicians and the hospital managers, we decided to remove thyroid patients from the KPIs because we realized that the bottom line was that why were they not being discharged on the same day? Well, it turns out it was medical decisions with solid ground. So they were not going to change those medical decisions. So then if you're not going to change those medical decisions and you have good reasons for that medical practice, then remove it from your KPIs so that you can have more realistic metrics, and they can still come through the DSU for structural booking reasons, but they will not longer inflate artificially your metrics. Now, the second insight was to nudge prescribing practices. And before I get into that, I need to tell you the why, the rationale, and a wee concept. So the rationale, why did we look at prescribing practices? Because opioids that patients receive for pain relief cause itch and nausea. That reduces appetite, and eating is one of the criteria for discharging patients. If you have nausea, then they prescribe you antiemetics, so to reduce drugs to reduce your nausea. So that's why we looked at these ones. And then what is an equidose? This is just an equivalence factor that enables us to compare drugs with different strengths on the same scale. Because, for example, fentanyl is much stronger than morphine. And so by using equidoses, we can compare drugs with different strengths. Right. So this is a result from our opioid-specific models. On the left-hand side plot, you have the different opioids and their odds ratio, so their effect on delayed discharges. And you can see that they vary greatly, right? So first of all, you can see that fentanyl is the only one that completely overlaps with 1. So it does not have a significant effect in increasing delayed discharges. Brilliant news. Then the second thing you have on the other plot is the frequency with which they are prescribed to patients. And you can see that dihydrocodeine, which is nearly trebles a patient's chance of being a delayed discharge, is a most often prescribed opioid. So opioids with the smallest impacts are not the most often prescribed. That was a serious problem. So what did we do with this information? Well, we changed that. So why were they being prescribed more often? It's because they were at the top of the hospital prescribing protocol drop-down menu. We know clinicians are pressured for time. They're super busy. They're doing their best. They are short on time. And so if they have no specific preference, they will just go for the top option on the drop-down menu. So instead of having a drop-down menu that has them ordered alphabetically or for any random reason, we change the order. So those with the smallest effects are at the top. A small change that we hope will bring a massive improvement. Then the third one is evaluating opioid consistency. So this means consistency between the opioids that are prescribed in the surgery room and those in the recovery room. They can be intravenous or oral opioids. So what is prescribed in the recovery room, we know because it's recorded electronically. But in our health board, what's prescribed in the surgery room, we do not know because it's recorded on paper. So the other thing that we do know is that intravenous and oral opioids differ in their probability of affecting delayed discharges. Here you have the number of opioids equidoses a patient received and the probability of delayed discharge. So the flatter the line, the better of a drug option it is. So we have fentanyl for intravenous and we have morphine and oxycodone for oral ones. So what did we do? We put these two pieces of information together and we, in close collaboration with both hospital managers and clinicians, very importantly, we launched a data collection piece to evaluate if what happens in the surgery mimics what happens in the recovery room. So we know the effects that opioid recovery room prescription have, and by mirroring that same thing in the operational theater, we hope to expand our efficiency gains. And finally, safeguarding our efficiency gains. For these, I need to tell you about a problem, the borders problem. Border patients are those that are not inherently DSU patients. They are just shoved into a DSU bed, day surgery bed, because there's no capacity in other parts of the hospital. But they are a big problem. They can account for up to a third of the patients in the DSU, and their numbers fluctuate greatly. They can reach nearly 50% with a temporal variations, right? So what did we do about this? Well, very simple in principle, but it stems from the close-knit collaboration with other aspects of healthcare. So we collaborated with the hospital managers to raise awareness so that we avoid feeling any efficiency gains in the DSU that we gain from this piece of analysis, to avoid filling them with borders, no? Right. So now I'm going to tell you quite fast about 4 other findings that we were quite pleased to know about from this analysis, which was an auditing, they fall more into an auditing piece, which I think is another of our great responsibilities as analysts. So looking at quality of care, deprivation effects, and other aspects that can make our day surgery unit more efficient. So in terms of quality of care, I'm going to show you these 2 plots of the odds ratios that either anesthetists or surgeons had on affecting patients' probability of being a delayed discharge. You can see that the names are deliberately obscured for confidentiality reasons, but all of them overlap with 1, the odds ratio of 1, which means we're proud to say that there's no evidence that any given surgeon or anesthetist affects a patient's probability of being a delayed discharge. Great. Homogeneous quality of care. Then moving on to health inequalities, we were really interested to know if deprivation affected patients' probability of being a delayed discharge. And here you have the deprivation quintiles on the y-axis, and you can see that they all overlap with 1. So we have no evidence that deprivation has an effect. And the other thing is we wanted to know whether there were any inequalities in access to pain relief. So again, the number of opioid equidoses a patient received and their deprivation quintile. Pleased to say that we have no evidence of health inequalities in access to pain relief. And finally, when we analyze the temporal effects, we found something quite unusual. So here are the odds ratios of the day of the week on the probability of being a delayed discharge. And if you're a Saturday patient, you're 2 times less likely to be a delayed discharge. So this is great. Why? So I was quite intrigued. And this is because as part of a waiting, as initiative to reduce the waiting list, they introduced a new modus operandi for the day surgery unit that's different on the Saturdays. And basically this means that however they work on a Saturday makes the day surgery much more efficient. You might also see that a Sunday patient is like 5 times more likely to be a delayed discharge, but that's a separate reason because technically the DSU does not operate on a Sunday. This is just reflecting emergency cases with a very reduced number of staff. So this is kind of expected because this is just emergency cases, not normal operations. So in terms of my conclusions, well, the DSU is 25% points away from their goal. We know now that most factors that are delaying the operation, delaying discharges, can be planned for if not changed, because they are known in advance. From that, we derived actionable insights. So we changed operational metrics to make them more realistic by removing thyroid patients. We also produced evidence-based changes in prescribing practices to improve the efficiency of the unit. We brought awareness to managers so that we avoid filling any gains with borders. We also realized that the waiting list initiative modus operandi that happens on a Saturday makes it far more efficient. So maybe something to learn from for the weekly operations. And then we are pleased to know that we have homogeneous quality of care. We're also pleased to know that there's no evidence of health inequalities in what we tested. And we're going to evaluate the impact of the changes that we implemented further down the line. This is going to be facilitated because we used a reproducible analytical pipeline. And before I close, I just wanted to hone in what were the key things to making this such a successful project. On the one hand, being able to link these massive amounts of data, so outpatient, inpatient, lab tests, diagnosis, demography, community prescriptions, theaters data, primary care, hospital prescriptions, and also, probably most importantly, the close-knit collaboration between analysts, clinicians, and hospital managers from start to finish. And a great kudos point for all my colleagues that helped with the data linkage. And with further ado, I hope I demonstrated to you the power of analyzing linked data to achieve strategic objectives, provided some understanding on the factors that delay discharges in DSU, and how we use them to produce actionable insights that improve healthcare quality. And happy to take any questions.
Thank you very much for that, Nora. An intriguing piece on the power of linked data and the benefits of that. There was some really staggering results in there, and great to see the analysis resulting in actionable insights. We've got about 5 minutes left for a Q&A, and there's a couple of questions in the chat which we'll just come on to. I just wanted to note that there has been an issue with attendees being able to see the sessions in this stream, and there has been a temporary fix sorted. So now we've I think it was around the start of this Nora's presentation. I saw a lot more people join, which is great, and the team behind the scenes are just working on that to get it more of a sustainable fix in place. But so we'll just now move on to the Q&A segment. So we've got a question from Julian. How easy or difficult was it to get the clinicians on board with changing their clinical practice? And did you get the common, "Oh yes, we know that, and why it happens," answer for any of those changes?
That's a great question, Julian. Thanks very much. So I think we were quite lucky in that the clinicians had a very strong interest in actually understanding what was a problem or what factors contributed to that. So I would say the answer is it was easy, but it stemmed from the fact that this was a long-term project. It developed over 12 months and we had very regular recurrent meetings with the clinicians. So you kind of build that relationship where you provide constant feedback and demonstrable evidence. And so basically you say, this is what the data shows. By this time, you've already had a rich dialogue. So you have a tiny bit of understanding of how it operates. And then you say, based on this data, and I'm the data expert, you are the ground expert. Let's see what we can co-design together. And so they obviously provide the functional insights. And I would say it came about quite natural, but because it was founded on this long collaboration and, oh yes, we know that and why it happens. That's exactly what happened with the waiting list initiative. So if you see that the Saturday one was less likely to be a delayed discharge, I was like, I don't understand why Saturday and Sunday are so contrasting. And then they were like, well, Sunday, it's because it's emergency procedures, but Saturday, it's actually quite interesting. And it's because the day surgery operates very differently. And they knew that. And then they were like, okay, we're going to escalate this to the managers to see what realistically can be improved during the week. And basically, it's very simple. It's because during the week, they have a fixed shift pattern. So the nurses and staff have to stay until the end of their shift. So normally, apparently, there's some tasks nurses and ward staff don't like to do. And so they delay other aspects. So they don't have to go and order the cupboards and stuff like that. But on a Saturday, they get to go home as soon as they finish. So they don't expand tasks to take up time. They just get it done and that's it done. How much can that be changed on the weekly procedures? I don't know, but at least we know there's an effect. Yeah.
That's right. Yeah, it's really interesting to hear about that Saturday and the difference between the two. And just a final question in the last couple of minutes we've got from Hannah. Did you look at health inequality factors other than deprivation? Hannah can't remember whether ethnicity and gender are included in the model as well.
Well, we included sex. We don't collect data on gender, but we included sex. And ethnicity. I don't think I included ethnicity. Our ethnicity data is quite patchy. I just presented it and I actually can't remember. I'm going back on my slides to give you a correct answer. No, we did not include ethnicity. We include other things like next of kin, because there was whether patients had a next of kin declared on the system. But yeah, sorry, we did not include ethnicity.
Thanks for oh, we've got a bit of background noise there, but that is us at time.